sir. I think it's an honor to be chaired by Professor P.V. Rao and Dr. Rajendran. I'd like to thank Dr. Vijayakumar for asking me to give this talk. It's a very important talk, and I think every diabetologist, physician should know about some of the surgical aspects involved in diabetic foot care, which I'll be showing to you in the next 12 minutes. My talk will be for about 12 minutes. Now, the foot is such a marvelous structure. In fact, the great artist called Leonardo Vinci said that foot is the most marvelous of all the arts which he has thought he has seen. Leonardo Vinci was the one who drew Mona Lisa, which is there in the Louvre Museum, because the foot, the human foot, has got about 27 bones, 19 muscles, and 32 joints. And you can see that it's such a complex structure which we don't realize when we start walking. And by the time we have ended our life, we would have circled the globe 5 times. We would have covered that much distance in our lifetime that we would have circled the globe 5 times. That's the amount of walking which we do when we which we don't realize. But this is what happens in diabetes. It's a totally ischemic, what we call as Wagner's grade 6, which is just not salvageable. So this is what we see. And in the next 11 minutes, let us see how we can prevent this situation among our people, among our patients with diabetes. Because losing a limb is a disaster, not only for the person. For instance, he was a bus driver. This man was a bus driver. The mouse is working here, but it's not working there. So it won't work here, no? Because it's not showing that here. This man whom you see there, okay, I'll use when I show the mouse here, it won't come there, no? It's not it's not coming. So this man, okay, I'll show this. No problem. This man was a bus driver, and 1 minute. And he lost his leg and he lost his job because the PTC was not ready to give him a job after he lost his leg. And this is an excellent slide from David Armstrong, which I borrowed from him, which shows that the amputations produce as much death as breast cancer. We cry from the rooftop about breast cancer and prostate cancer, but we don't realize that neuropathic ulcers cause twice as much death from neuropathic ulcers than does prostate cancer or breast cancer. So that's because, as Arnold Bloom said, the diabetic patient, when he has cataract or retinopathy and when he has neuropathy, he's actually divorced from his feet. He can't see, he can't feel, so that's a problem. And way back in a small island in Italy, the St. Vincent team said that we have to reduce amputations from gangrene by 50% in 5 years, in 1990. And it's 28 years and we are nowhere near reducing this number of amputations due to diabetes. And then the WHO said and the IDF said in 2005 that we should prevent amputations. But I don't think we are anywhere close to this target. Now you see this study which we published in JAPI some years ago, where we collected information from 31 diabetologists from across India, from Jammu and Kashmir to Tamil Nadu and across west to east. 31 centers, data on amputations in about, you can see that about 1985 amputations were taken from 31 centers, east, north, and so on. And you can see that the most important reason for amputation was neuropathy and infection, 90%. And trauma is also due to neuropathy. So nearly 95% of the amputations was due to neuropathy. And this is a study which we did along with Nihal Thomas from CMC, Nikhil Tandon from AIMS, and Dr. Arthur Harsarvadam from Rajaji Hospital in Madurai. And we found that, again, neuropathy was present in about 10 to 17% of the outpatient clinics in Madurai, Vellore, and Delhi, and our own institute. Whereas peripheral arterial disease was only about half of that number. For even today, neuropathy is much more prevalent than peripheral arterial disease. And we are thankful to that, because if you have peripheral arterial disease, it's a real nightmare. But is it possible to prevent amputations in our country? This was a paper which we published about 15 years ago, 13 years ago, where we showed that in diabetes care that if you just educate your patients long enough and fair enough, you can prevent amputations. So this is a very good study where we looked at patients with ulcer, without ulcer, and so on. We found that by just educating the patients, you can prevent amputations. So this brings us to the last maybe 6 to 8 minutes of the talk. And the one thing which I would like you to realize is, when you talk about the foot in people with diabetes, we have something called high-risk foot, which is a stage at which, and normal foot. And stage 1 and stage 2, if you miss, then you are in trouble. This is a simple classification given by Mike Edmonds from King's College London. And once you get into the stage, once you miss this, then the person gets into ulceration, infection, necrosis, and so on. Therefore, for us diabetologists, this is what is the most important. And I'm going to focus my entire talk on this. But in the last maybe 2-3 minutes, talk to you about infection and necrotic foot also from a surgical standpoint. Now, as I said, peripheral arterial disease is important, but what is most important is somatic neuropathy, autonomic neuropathy, producing a neuropathic ulcer in the Indian setting. About 20% of our foot infections are due to ischemia, so we should know how to manage peripheral arterial disease. But before that, we need to know how to manage somebody who does not have sensation in his foot, because he has not only sensory motor neuropathy with all these concomitant features, but he's also got autonomic neuropathy. And the most important thing as we physicians we need to do is to select somebody from our team. For the last 25 years or 27 years, ever since I entered the MV Hospital for Diabetes in Royapuram, I have trained at least about 200 BSc home science graduates, dietitians, and physiotherapists, and so on. You can suitably train anybody to examine the feet, because we do not have time. Nurses just do not like to examine the foot. They like to give intravenous catheters and so on, but they don't like examining the foot. Therefore, what we have done is to train BSc home science, zoology, botany. They don't get jobs that easily. If you finish BSc botany and BSc zoology, you don't get good jobs anywhere. So just train them up to examine the foot, and it's very easy. So in the next 60 seconds, please listen to this. We do not need the biothiosiometer. We do not need those high gadgets which people are doing in their clinics, examining the pressure and so on. Andrew Bolton from Manchester just said that if you examine the vibration perception threshold with a 128 Hertz tuning fork, the right side, left side, and if you can't feel it, put 1 here, 1, 1, okay? Then use anything you want. You can even use a tuning fork, or you can use a test tube of hot water and cold water. Examine the right side and the left side on the dorsum. If you can't feel, 1, 1, okay? Then use a blunt or a sharp object and apply that pin proximal to the big toe nail, just enough to deform the skin. If you can't feel, you get 1, 1. So supposing a person has got 1, 2, 3, 4, 5, 6. Now for the tendon reflex, if we can't feel it, it's 2, 2, okay? 2, 2. So that makes it 10. Now, what Andrew Bolton and Carolyn Abbott showed was, if you have, and they did it in a long-term prospective study, if you have more than 6, a score of more than 6, your annual incidence rate of getting an ulcer is 6.3, vis-a-vis somebody who's got less than 6, whose annual incidence is only 1.1. Therefore, if you have 1, 1, 1, 1, 1, 1, this itself, if your tendon jerks are normal, but even if you get all these, it's 6. Okay, so if you have more than 6, you are definite that this person is going to ulcerate. So you have to be very, very careful. So this is how you detect a high-risk feat. Of course, way back 17 years ago, we published this data of a graduated tuning fork, which you can see in the next picture, which is nothing but a 128 Hertz tuning fork with graduation. And we compared it in this study, which we published in Practical Diabetes International, with the biothiometer, and it was as good, 90% sensitivity, specificity compared to, so you don't need the biothiometer. All that you need is this 50 pounds Riedel Seifer tuning fork, which you can keep in your coat pocket and examine the foot. And then in the Postgraduate Medical Journal in 2002, we published for measuring temperature, because it's very difficult to get a test tube of hot water, cold water. In an air-conditioned room like this, the patient is asked to identify the metallic end and the wooden end. It's called the tip therm. It's also available for sale in India. And the patient says he can feel the cold. So you're stimulating the small fibers, the C fibers. So you can examine this also. But it's better you combine one or two methods, as Aaron Winnick and Bolton showed, that if you combine two methods, monofilament with vibration or whatever, your sensitivity specificity will be much more than using one particular method. And don't forget to examine the limited joint mobility, because we showed about 15 years ago that if you don't have, just as you have limited joint mobility in the hands, and you talk about prayer sign, keeping the hands together, you can put your feet together and examine like you do in the hands. So what you do is you just dorsiflex the big toe. If you can't dorsiflex above 60 degrees, you have limited joint mobility. And we showed in the study that there is a very big correlation between limited joint mobility and high plantar pressures in Asian Indians. Therefore, using one of these methods, you make a diagnosis of what we call at high-risk foot, a foot which is at risk of amputation. So if you have loss of protective sensation, if you can't feel the posterior tibial pulse or the dorsalis pedis pulse with the hands, if you have deformity in the feet, either, it's one or more. Even if you have one of these, it is high-risk feet, not a combination. If you have a past history of a foot ulcer or a prior amputation, or if you have limited joint mobility, if you can't move the big toe beyond 60 degrees, if you have even one of them, you have to tell your patient you are in a very high-risk category of an amputation. Let me close in the last 5 minutes on some of the technologies which we have to treat patients with foot infection. The first part of my talk was how to prevent in a high-risk feet. Now we have technologies like this for the last 6-7 years, the negative pressure wound therapy. It has completely revolutionized the management of wounds and diabetic foot wounds, because you apply the sponge onto a wound which is not granulating. It sucks up the exudate and the interstitial fluid, and it makes the capillaries open up. Therefore, before applying this sponge, which is part of this VAC therapy, onto the wound would have been sloughy, yellow, and so on. But the moment you remove it after 4 days, you will find it like a tomato or like a strawberry, because the capillaries would have opened up. Hyperbaric oxygen we have been using for the last 6 years, but it's useful only if you have already done a revascularization. If you try to attempt somebody with an ankle brachial index of 0.7 without doing a bypass to the leg or tibial angioplasty, it simply doesn't work. Because we published recently a paper where we showed that hyperbaric oxygen is definitely useful in people who have undergone an angioplasty in the leg, tibial angioplasty or a peroneal angioplasty, and you have improved the blood flow. And you can see that before applying the hyperbaric oxygen, this is how the magnified tissue looks like. There's hardly any vascular tissues which you see. Whereas if you see after applying, you can see the typical folds and capillary formation, which is classical of healing. From the previous picture, you don't see any signs of healing, whereas after hyperbaric oxygen, you can see fantastic healing. I'll give you the last 2 minutes of my talk this classic example where a multidisciplinary team is important. This patient comes to us with a very infected ankle wound, and it's a sure case for an amputation, absolutely sure, because the ankle joint is involved. The ABI was 0.5, critical limb ischemia, with infection, with the ankle joint completely destroyed, and pus pouring out of this wound. So what we do is, first you do a debridement, it's a case of necrotizing fasciitis, open up the wound, And then here you can see the exposed tendon. You can see the ankle joint is completely exposed here. And then what you do is you do a wound debridement and clean up the wound. And then you do a bypass, okay? You do a superficial femoral artery to a distal popliteal bypass on this patient. Or you can do, if the patient is lucky, you can do an angioplasty if it's plastiable. And then you apply what is called an external fixator or Ilizarov ring, where you stabilize the ankle joint by putting an Ilizarov ring for about 6 to 8 weeks. And finally, you put a skin graft, close the wound. That's it. So the whole process takes about 2 months, but you have done an angioplasty, and then this patient also had VAC therapy and also hyperbaric oxygen. So you can see by a multi-pronged approach, this lady's blood sugar, this lady from Erode, her leg was sort of saved, and she came 2 days ago also to see us walking, because otherwise she would have come with an artificial leg. So I think there are some cases which are complicated, but all these technologies are available in India very much, and the total cost would have been about 2 lakhs for her in a private setup. Therefore, the last slide of my talk is regular inspection and examination of the at-risk foot. You don't need any expensive gadgets to make a diagnosis of at-risk feet. As I showed you, the NDS has only temperature, tendon jerks, and also a 128 Hertz tuning fork. Identify the at-risk foot. Educate the patient, family, and healthcare providers. Footwear is very important, especially if you have a deformed feet. And I'm somehow not too keen on this MCR footwear, which is being sold like Hawaii chappals outside in shops. I'm totally against this MCR footwear. I've not used it for the last 26 years. And then treat the non-ulcerative pathology by removing the callus and removing the pressure under the foot. This is a small thing which I started called the Diabetic Foot Research India. If any of you are interested, you can log on. We have about 150, we've already published 2 papers, multicentric studies online. There's no papers. You can just log into this website and feed in your patient's data. There are 2 ongoing studies, DFRI.in, to publish data from across the country. I thank you for your attention.